Hi, this is Elliot Fishman, and welcome to our latest vodcast. And this is going to be a two-parter. What I'm going to do is I'm going to look at the IVC, the inferior vena cava, look at a spectrum of disease. I won't go into a lot of rare things, but some of the basic things we're going to look at in terms of practice. Now, the truth is the IVC is evaluated on MR, it's evaluated on Doppler ultrasound, and evaluated very well on CT. I think what's very important is that sometimes we have cases where it's rule out IVC thrombus, but most of the time it's the pathology you're looking at, and you look at the IVC secondarily. So for example, if you're thinking about renal cell cancer and you're staging, you're looking at renal vein and IVC for spread. Similarly, you could say the same thing looking at adrenal carcinoma or hepatoma. In patients with trauma, we look at the IVC to look, is it patent? Is it narrowed, like a flattened IVC in a patient who's hypotensive? We look at fistulas from the IVC in tumors. Again, in terms of 2D mapping and 3D mapping, the IVC becomes very important in terms of surgical planning, and CT provides lots of additional information in that area as well. In this talk, I'm not going to speak about 3D mapping of the IVC for surgical planning. That's something that I think will be the subject of a different talk. Now, if we just go back for some basic anatomy, the IVC is formed by the confluence of the right and left common iliac veins draining blood from the lower extremities and pelvis as it ascends in the retroperitoneum to the right of the abdominal aorta normally. It receives major tributaries, including the lumbar veins, the left and right renal veins, the right gonadal vein, and the hepatic veins. The azygous venous system connects to the IVC either directly or through the renal veins. The IVC and its branches are best demonstrated in the coronal plane. Now, in terms of anatomic variation, the IVC is formed between the 6th and 8th weeks by the sequential formation, anastomosis, and regression of 3 paired veins, the posterior cardinal vein, the subcardinal veins, and the supracardinal veins. It is composed of 4 different segments: infrarenal, renal, suprarenal, and hepatic. Aberrations in the complex embryology of the IVC result in several potential anatomic variants, which are present in about 4% of the population. Variation in the number and position of the left renal vein are even more common. Most anomalies are found incidentally, although patients with anatomic variations are considered at risk for developing deep venous thrombosis of the femoral or iliac veins at a younger age. They may pose a special challenge at surgery and should be carefully described in individuals considered for laparoscopic donor nephrectomy, for example. The most common anatomic variants include the retroaortic left renal vein, double and left-sided IVC, and a circumaortic left renal vein. Some anomalies, particularly the azygous continuation, have been associated with significant congenital heart disease. Some examples: the anatomic variant of a circumaortic left renal vein. It's the most common anomaly found incidentally. In about 8% of the population, 2 renal veins are present, with the superior vein crossing over the aorta anteriorly. The posterior vein often lays much lower than the anterior vein, and this can be a challenge if you're doing a donor nephrectomy. And again, one of the things when I do renal donors is I look very carefully at the patient's renal veins, both for numbers and location. Here's a potential donor, nice example in 3D of the circumaortic left renal vein. You can see the size of the renal veins in this case is about the same. The anterior component is typically more superior. In some cases, the retroaortic component particularly is going to be a bit smaller. And here's just a few more images from that same patient. Now, a left-sided IVC, persistence of a left supracardinal vein with regression of its right counterpart results in a left-sided IVC. The infrarenal IVC is found to the left of the aorta up to the level of the left renal vein, which then crosses anterior to the aorta and joins the right renal vein and forms a normal right IVC above that level. I think the biggest challenges or confusion I've seen with the left-sided IVC is occasionally, if people don't recognize it, they call adenopathy present when there's no adenopathy. Double IVC, the anomaly results from persistence of both supracardinal veins. Typically, left IVC ends at the level of the left renal vein. Again, usually very nice symmetry as you track downward. Typically, particularly on contrast studies, it's no problem. Again, the thought of confusing it with adenopathy is a consideration, but usually it's not going to be a problem because both components are fairly symmetric. Now, azygous continuation of the IVC. In this anomaly, the right supracardinal hepatic anastomosis does not form, the hepatic IVC is absent, and blood from the renal IVC drains into the azygous system to empty into the SVC. Again, this can be somewhat confusing. It can simulate adenopathy. Here was a case in a patient with pancreatitis. You can see it's to the left of the aorta inferiorly, again, almost looking like a node. Then you see what looks like subcrural adenopathy, but it's just that azygous continuation. And then you have a prominent azygous, which at times on a chest x-ray could look like a widened mediastinum. Now, in terms of thrombus, we're going to speak a lot about thrombus in the IVC. Most of the time, we like to consider it related to tumor. I mentioned renal, adrenal, liver. We can also see it from synovial sarcomas, unusual retroperitoneal mass, which is aggressive. We could see it with endometrial stromal sarcoma that arises from the uterus but classically involves pelvic veins, grows upward into the IVC. Bland thrombus can be due to patients across a range of possibilities, from hypercoagulability states, venous stasis, malignancies, local compression of the IVC by adenopathy, large retroperitoneal masses of fibrosis, as well as venous stasis in foreign bodies such as IVC filters or catheters are known to promote local clot formation. The persistence of a filling defect within the column of contrast leads to the diagnosis. Of course, you need to be very careful looking at timing. If you're scanning more toward arterial phase, you can end up with a pseudothrombus in the IVC. If you're not certain, simply getting delayed phase images will make life very simple. As I mentioned, pseudothrombus can be problematic. It's particularly an issue when you have slow flow or you're in early arterial or even mid-arterial phase imaging. Other causes of pseudothrombus include streaming of opacified blood, refluxing into the hepatic veins from the heart, usually in patients with right-sided heart failure, typically when there's rapid injection of contrast. As we mentioned, in equivocal cases, delayed imaging really makes life very easy. In patients with parenchymal liver disease, prominent pericaval fat may appear to project within the lumen of the IVC, a rare cause of a pseudothrombus. And I'll show you two cases. You can see here, you just don't see the IVC, but then you see something, you say, oh my goodness, this looks like a thrombus here. But it's really not, it's really a pseudothrombus. There is no thrombus present. And here's just one more example. Once you've been fooled, and all of us at some point were fooled, it looks like an IVC sarcoma. Maybe it's a liposarcoma in the IVC, though the IVC is not distended. And then when you look at all the images, particularly at coronals or sagittals, you'll realize exactly what you're dealing with. Now, in terms of IVC thrombosis, malignant thrombus, with renal cell being the most common malignancy extending into the IVC, it's been reported in up to 10% of patients with renal cell carcinoma. Again, the importance of accurate staging, the importance of coronal reconstructions and 3D mapping. According to TNM classification of renal cell, tumor spread into the infradiaphragmatic portion of the IVC is categorized as T3C stage, while extension intra the supradiaphragmatic IVC is classified as T4B. It's very important, of course, to determine how extensive the thrombus is. If it goes into the patient's right heart, into the right atrium, then if surgery is done, you'll need both a thoracic and abdominal approach. While the tumor thrombus is confined to the infrahepatic IVC in about half the cases with IVC extension, 40% of clots involve the hepatic IVC, and probably under 10% of patients demonstrate clot in the right atrium. But again, you need to look very carefully. Here's a few schematic diagrams showing you, first diagram on your left, IVC thrombus with extension from renal vein. You can see in the middle image, the thrombus is extending higher intrahepatically, and on the third image, it extends up to the level of the IVC and right atrium. Now, recent studies comparing CT and surgical findings show a very high accuracy for CT with sagittal reconstructions and coronal reconstructions in 3D. We actually published a paper which showed basically 100% accuracy. At some point, it can be a bit of a challenge if you don't have the right phases, but typically it's a very easy process to do. Sometimes the question is the thrombus in the IVC tumor thrombus or bland thrombus? Particularly with renal cells like clear cells, you often see neovascularity, so that'll make things a little bit easier. The diagnosis of invasion of the wall of the IVC is more difficult on imaging and is best assessed by careful evaluation of the axials, but also coronal images. Demonstration of arterial recruitment from adjacent organs may also indicate vessel wall invasion. In addition to renal cell carcinoma, other tumors that frequently spread to the IVC include hepatoma and ACC, as well as Wilms tumor in children. In cases where you're uncertain based on CT, MRI may prove to be helpful. And here's a very nice example of a large left renal carcinoma. You can see the tumor is extending into the IVC via the left renal vein, very nicely shown on the sequence of images. And in the second case, tumor extension, renal vein, IVC, up into the patient's right atrium. So again, two different examples, very nice definition of tumor. Another case here where you can see the malignant thrombus because of the neovascularity that's seen in the IVC. Or in this case, where you see the renal vein involvement up into the heart. Again, these schematic drawings, I showed you a couple of them before, really help you in thinking about the process. In terms of renal vein involvement, it's more common for renal vein on the right to extend into the IVC because the vessel is shorter. Here's a nice example of a very vascular clear cell, and this is thrombus going up into the IVC, but it's malignant thrombus because not only is a thrombus distending the IVC, but there's extensive neovascularity, and that really is a great point. Neovascularity means it's malignant thrombus. Here's another case with IVC involvement, renal cell. The question here is this thrombus or flow related? It's early phase. When you go a little bit later, you can see that it really is going to be tumor thrombus growing up IVC from the renal vein. Again, if you're uncertain, the later phase images, here's the venous phase images, which are the optimal phase. You can see the hepatic veins and the thrombus and tumor in the IVC extends upward, but not all the way up into the patient's right atrium. It stops before the origin of the patient's renal veins. Another example here, this tumor is not quite as vascular, but you can see the renal veins are really distended. And then you follow it upward to the IVC. You can see the tumor growing up into the IVC, coming up near the diaphragm. Not a lot of neovascularity in this example, but look how we track it upward. Here is a dilated IVC with tumor thrombus. Here you can see it's present at the level where the hepatic veins enter, and it ended just before the patient's right atrium. Another example, clear cell, marked neovascularity, really impressive extension of tumor into the IVC. Again, you're not going to be thinking about bland thrombus. That neovascularity makes it really, really easy. In terms of tumors, papillary renal cell very rarely invades the IVC or even the renal vein because it's less aggressive. Most of the time it's clear cell. Now clear cells are more than 80% of renal cell carcinomas, but it's this neovascularity that really makes it easy. And in this case, it's into the IVC, renal vein, IVC, but not into the patient's right atrium. In terms of imaging, we made the point before that axial is a good start, coronal is helpful, sagittal is a little bit helpful, but it's really things like MIP and volume rendering. MIP is particularly good at looking at neovascularity, and that's shown very nicely in this example. Now, the next thing I want to talk about are primary tumors of the IVC. Primary tumors of the IVC are very rare. The most typical one is leiomyosarcoma. So let's do this. Let's stop right here and let's come back in a few minutes and talk about primary tumors of the IVC. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.